Right now, we have three covalent BTK inhibitors where there is a lot of data to support their clinical use. There's been two relapse refractory CLL studies, one in high-risk disease, the ELEVATE-RR, that compared Ibrutinib to Acalabrutinib, and then the ALPINE study comparing Ibrutinib to Zanubrutinib, which was all previously treated CLL. ELEVATE-RR did not have a progression-free survival difference. ALPINE favored Zanubrutinib. So I think that that's important to think about. Of course, Acalabrutinib and Zanubrutinib haven't been directly compared, and there's some differences in the study, so it's not clear that Acalabrutinib and Zanubrutinib are really different. But the side effect profiles of these are different. So specifically related to cardiovascular side effects, Ibrutinib has a higher rate of atrial fibrillation in both these studies compared directly to the second generation, either Acalabrutinib or Zanubrutinib. And also at Ohio State here, Daniel Addison and my colleague Seema Bhatt have done some work looking at ventricular arrhythmias. Other groups have done this too. You can see it in clinical trials. It does look like Ibrutinib has a higher rate of sudden cardiac death and ventricular arrhythmias than the other drugs. Although I'm not sure the other drugs completely escape that risk, it is higher. And then hypertension is higher risk with Ibrutinib. So I generally select either Acalabrutinib or Zanubrutinib for my patients. Zanubrutinib was recently approved in the United States, so I have less experience with it to date. But I think this really makes that a better choice based on this randomized data. The safety data, I do think, would translate to a previously untreated population. So I have no trouble saying that the safety data probably applies to untreated CLL. The efficacy data, I'm not sure.